Hey everyone, Jeff from Lewis Physical Therapy and Sports Rehab here. We are going to talk today about shoulder labrum injuries in pitchers. It is really, this can be a very much more in-depth topic. I'm going to cover some general overview and then some general treatment approaches today, but it's important because a lot of times pitchers with labrum injuries, the minute they hear labrum, they think I need surgery and whatnot. And there's, especially with labrum injuries, you have to take an aggressive non-surgical approach first because the outcomes after surgery for labrum injuries in pitchers are not as good compared to other injuries. Again, if we're talking non-pitchers labrum surgery, it's still a tough surgery, but the demands that labrum undergoes for pitching make this a very hard surgery to come back from. So, kind of starting with the function of the labrum. The shoulder is the most mobile, unstable joint in the body. So, as a result, you have to rely on other structures in the area to improve stability, especially from a pitching standpoint. Your rotator cuff, your capsule, and your labrum. So again, your labrum, more than anything, is a structure in between the golf ball and the tee to help improve stability more than anything. So that's kind of just the kind of quick summary of what the labrum is. There's a lot of other kind of things we can go into, but for the purpose of this video, the labrum is meant to improve stability. And then really from a standpoint of pitching, that labrum does get some excessive mobility, what this is called your peel back mechanism, to allow for greater layback. So when we go into different types of labrum injuries, kind of the two big ones we see are your SLAP, superior labrum, anterior to posterior injuries, which typically in these individuals is much more of this kind of bicep specific, anterior shoulder pain, especially when they get into layback or coming out of layback. In these cases, for those that say they get a SLAP repair, they might get a bicep tenodesis as well. There's some kind of, there's a debate on whether is it the labrum or the bicep tendon that's the pain generator. So that's a lot more that kind of classic presentation for SLAP lesions is on the front of the kind of maybe front side of the shoulder. And then we have internal impingement. So internal impingement is essentially the kind of classic things we start to hear from these individuals is when they get into layback, they just get this posterior joint line pinching, right almost on the back of the armpit. When they get into layback, they get this pinching sensation, which is essentially that labrum and the rotator cuff that's coming around getting pinched between the glenoid fossa and the humeral head. And that traditionally is due to a hyperangulation of the humeral head. So meaning that humeral head is very positioned forward, so as a result, they get a lot more closing on the back of that joint line more than anything. So this is more of the kind of chronic labral injuries we see in our pitchers. Certainly you can have traumatic injuries that leads to bank heart lesions, dislocations, subluxations. I'm not going to go into that right now. We're talking about more of the chronic labrum injuries in these pitchers. So that's kind of a quick overview. In general, not always the case. For your SLAP lesions, you typically have a little bit more of this kind of anterior, maybe a little more lateral versus internal impingement is typically a lot more posterior, lot more posterior shoulder pain. Surgical versus non-surgical outcomes. So my style of treating shoulder labrum injuries is you do everything you can to avoid surgery in these individuals. And if they fail one course of rehab, conservative, you do another course of rehab. The main reason being is because when you are pitching, that labrum needs to undergo what we call a peel back mechanism. So it's literally when you get into layback, that bicep tendon creates a torsional stress on the labrum. It literally pulls part of the labrum away from the glenoid, and that allows you to get into more layback. The biggest issue for guys after labrum surgery, labral repair, is getting layback, that maximum external rotation back. That's the hardest part for some of these guys, and maintaining external rotation strength. Guys do get back, but what we need to be mindful of is even when guys do get back, we need to make the expectation. Even if they're a outfielder, but especially a pitcher, don't expect them right away to be back to their prior level of performance. It takes time. You hear all the time of guys come back from labrum surgeries like ACL. They might not feel like themselves or pre-injury selves for a year or 2 years after surgery. And it doesn't mean that there's anything wrong. It just takes a long time because the labrum has a large proprioceptive awareness standpoint, and that takes time to build back for individuals. So again, in general, you want to go as aggressive non-surgical rehab as possible. And we're going to touch on some other things here. The approach down here is very much the same, but with surgical, the hardest part is getting layback back for guys more than anything. Okay, so going into the more kind of, the treatment style of things, you need to very closely monitor their range of motion. So specifically their total range of motion, so total rotational range of motion, internal plus external, their adduction, cross-body adduction, and their flexion with and without their scapula pin. So with the scapula pin, you're looking at more lat teres. Without is kind of more pure shoulder flexion more than anything. So when I mean closely monitor, I am measuring this probably every day that a guy comes. If I'm treating one of these individuals, every day a guy comes in, I'm measuring this. Even in my elbows and stuff too, I measure that. But we have to very closely monitor this because we need to make sure that they do not start tightening up in that shoulder as a response to throwing, because as a result, it's going to shift stress elsewhere, and the last thing we want is that stress getting shifted down to the elbow. I've said it before. The biggest concern for guys coming back from a shoulder injury is an elbow, and the biggest concern for guys coming back from an elbow injury or surgery is the shoulder. So we need to very closely monitor their range of motion. There's other videos on my channel that go more specifically into the values we are looking for on these, on these range of motion values. In general, I like to make sure we're within 5 degrees of their essentially their non-throwing side. But we need to very closely monitor that because that is going to a degree, gear us in which direction we want to go for our manual therapy, our manual tissue work of how we're restoring range of motion. Historically, in these individuals, it's cross-body adduction and really their internal rotation more than anything. But again, we are also very much looking at external because, not that I'm stretching them into external, but we're using, especially for guys with internal impingement, we're using external as a guide of how symptomatic are they. If they're a guy with a likely slap lesion, you get them an external. Are they getting that pulling on the front of the shoulder? Or if they're an internal impingement individual, are they getting posterior pinching more than anything? So that's all things we want to be mindful of. In general, once flexion tends to go down, that usually kind of feeds back into some more of these symptoms and tightness. External versus internal strength. When I was early in my career, I did just a ton of external rotation strength with these guys, which they need because once you have a labrum injury, it is so easy for that external rotation strength to go down more than anything. So we are doing a ton of external rotation strength and work with them. Now, what I want you to be mindful of is in these individuals, I might not do a ton of external rotation work up in 90-90. That is naturally a destabilizing position for the shoulder. So if we're trying to just get our pure cuff strength from an output standpoint, I'm probably going to do a lot down low here because when I get up top to 90-90, I have some lower trap work kicking in, some serratus, some posterior delt, in addition to our infra and teres, which is not a bad thing up there, but I'm going to use 90-90 as more of a lower trap and scap stimulus as opposed to kind of down here from an external rotation standpoint. And then internal rotation strength. This is a big one. I honestly, until the last 2 years, did not start doing a lot. I did it, but over the past couple years, saw more of the value of this internal rotation. Because what I started to see is when guys tended to, in certain individuals, when they started to get throwing, it was actually their internal, not their external, that was dropping down. I'm like, that's weird. Like, that doesn't make sense to me. And their internal rotation strength for most guys in these cases is really a better idea of two things. One, how well is their shoulder sitting in the joint? And two, what is their fatigue level looking like? So what do I mean by that? When we look at the labrum injury, again, you want to have a smooth, we call our joint centration. The humeral head is in that, as the golf ball's on that tee, humeral head in that glenoid, and you want to have nice, smooth rotation here. Well, with these individuals, especially internal impingement, what happens is they naturally have a predisposition of sitting a lot more forward in the joint and potentially up if you get a little more supraspinatus involvement in that internal impingement versus pure infraspinatus. So what I mean by that is you need to be able to train them to produce force anteriorly without falling forward. So to be able to produce force in this position within the joint like so. So I do a lot more higher intensity isometrics and work through the range from an internal rotation standpoint. From here, rotating forward, I'll do a lot of, if you look at my channel, if you look at overcoming Y isometric into a wall, a T isometric into the ground, things like that, that is teaching them how do they recruit, not their pec and their lat, not their pec primarily, but their lat and their subscap to promote that smooth internal rotation, anterior dominant rotation of the shoulder. So the other side of that is from a fatigue standpoint. If a guy started telling me, man, listen, my throwing's not been great, I don't feel like I have that kind of pop, and their internal rotation strength is starting to go down, that's starting to get me think that, okay, this labrum is starting to get a little bit overloaded. We got to find some other stuff at play here. So just a couple things to be mindful of. External gets talked about a lot, which is important, but we cannot, and we absolutely have to be mindful of the role of internal rotation strength and how it plays into stabilizing of the shoulder and just monitoring from a fatigue standpoint more than anything. And the last part here is the lower half and trunk mechanics. I'm not a pitching coach. However, there are certain things I've been able to pick up from working with a lot of pitchers in terms of how it relates to the labrum. I say in general, for most of the guys that I found labrum issues, there is likely some type of lower half or trunk mechanical fault at play. That could be, there's a lot of different things here. I'm not going to get into that right now, but we need to be mindful of, is there stuff going on below the chain that is causing them to either be in a excessive horizontal abduction, so that here's where they're at, their arm is way behind their body, so are they getting a lot of stress throughout that anterior shoulder from a slap standpoint, or are they closing down too much on that posterior shoulder without scap recruitment, so more here versus here, Or at follow-through, are they not using their front side well, not getting a good front side brace, and as a result, they're decelerating all with the back of their shoulder, which in an internal impingement case, you're going to have an infraspinatus that's already lit up, and now you're overloading it from a deceleration standpoint and feeding into these symptoms. So again, that's outside the scope of this video. There'll probably be another video at some time about that from just a rehab standpoint, the implications of that. But we have to make sure that if you either do not feel comfortable identifying that yourself, which is completely fine. I didn't learn any of this stuff until I started seeing a lot of it, but you at least find some individuals that are a little more, that have the knowledge of it, learn from them, or send those individuals to there to make sure you are addressing what needs to be addressed early on in rehab, so you don't get to a bullpen. You're like, okay, well, these mechanics are all out of whack now. So these are just some general tips, again, of identifying and treating shoulder labrum injuries in pitchers. If you are dealing with this yourself or you're treating individuals with this, and you have questions, drop them below in the comment section and subscribe to our channel for more content like this.